Hey everybody, this is Andrew Wolf here, and in this video I'm going to be talking about the pathophysiology of coronary artery disease, including stable angina and the acute coronary syndromes, including unstable angina, and then the myocardial infarctions. And I'm not going to get into a whole lot of differentiation between the non-ST elevation MI and the ST elevation MI. I'm just going to sort of talk about myocardial infarctions in general. Now, before I begin talking about the pathophysiology, I wanted to talk a little bit, just sort of a brief review of the physiology of coronary circulation, and then also a brief review of just the anatomy of the coronary arteries. So, here I have a picture of, sort of a rough outline of the heart with a picture of the coronary arterial circulation. Now, if you look over here on the left side of the page, I have a blown up picture of the aortic root, and off of the aortic root we have our right coronary artery and our left main or left coronary artery. So all of the circulation from the heart comes from the aortic root, from either the right coronary artery or the left coronary artery, otherwise known as the left main coronary artery. Okay, now what's interesting, and I know this is a review for most of you, but what's very interesting about the heart, every other part of the body is perfused during systole. So the arteries are perfused during systole. However, because the cardiac tissues are compressed so strongly during systole, the arteries would actually be completely compressed and blood flow would not be possible through the arteries because the pressure, the intramural pressure, is so high during systole because of the contraction of the muscle. So the heart has adapted to have circulation during diastole, when the heart muscle is relaxed. Well, how's it done that? It's done that because in the aortic root, so the aortic root is where the aorta attaches to the heart. In the aortic root, there are the anastomosis between the aorta and the right coronary artery and the left main. And during systole, they are covered here. You can see these little yellow valves here. They get covered up by the aortic valve. And then during diastole, these valves close up. Because, remember why? Because of the back pressure of the blood with diastolic pressure, right? So that pushes the valve closed, and when the valve in its closed position, the coronary arteries are uncovered, and the blood is able to flow by the back pressure of diastolic pressure into the coronary arteries. So the coronary arteries are therefore in that way perfused during diastole. Now I'm going to talk about the effect of atheromas and atherosclerosis on the coronary arteries, because that is sort of the center part of coronary artery disease. So if you have not yet viewed my video on the pathophysiology of atherosclerosis, I'm putting a link up in the right hand corner of the screen. You can click on that link and watch that now before going on. So coronary artery disease is a disease of atheromatous plaque formation in the coronary arteries. So it's very common to get one in the left anterior descending artery, or one of the diagonal branches, or the right coronary artery. And if you're very unfortunate, you can have actually one in the left main, and that gives you very significant symptoms. Or you can have one in the circumflex. Now, typically people with coronary artery disease have disease in multiple vessels. That's why it's very rare for people when they one of the ways of correcting a coronary artery disease is to actually bypass the artery, and and you know, it's very unusual to see a coronary artery bypass graft times 1. Typically you'll see a cabbage times 3, or you know, up to 5. And just to give you a brief, since I'm discussing cabbages, I'll just give you a brief review of what a cabbage is. So the cabbage is usually they will take a branch of the internal mammary artery, and they will actually connect it to a distal part of a coronary artery to bypass a significant atheroma in the left anterior descending or the left main. And then they can only use that once, so they can't use that for more than one vessel. So if they have to do a bypass for multiple vessels, then they have to harvest a little piece of vein or two from one of the lower extremities. So they're going to take the popliteal vein, and then they're going to take the vein and connect it to the aorta and bypass using a little piece of vein. Okay, so this here would be a picture of a coronary artery bypass times 3, or a cabbage times 3. And what they're doing is bypassing the areas of partial occlusion or occlusion in the vessels by using alternate vessels and connecting it to below that area of occlusion. Okay, so there's two classifications of coronary artery disease. There is stable angina, and then there are the acute coronary syndromes. Acute coronary syndromes. Now, stable angina is stable angina. Acute coronary syndromes will be further classified to an acute MI, a non-ST elevation MI, and unstable angina. Okay, so stable angina is defined by stable symptoms and very predictable. If you increase cardiac workload with increased activity, then you will have a predictable response with chest pain. So, you know, if someone's complaining that every time they walk up 2 flights of steps they're having chest pain, this may continue for quite some time and just will slowly increase in frequency. So maybe a year later they'll be, you know, get the same pain when they walk up 1 flight of step. And you know, you can reproduce this with an exercise stress test. And when you do an exercise stress test, you will induce the symptoms of chest pain, and you will also see evidence of ischemia. And the evidence of ischemia will look like, whoops, ST elevation. And I'll get into what the EKG changes are caused by in a few minutes when I start talking about a MI. But this is reproducible. You take and you reduce cardiac workload by resting the patient, and the EKG will return to normal and the chest pain will disappear. Stable angina is caused by a fibrous plaque. So remember when we talked about atherosclerosis, we talked about how the fibrous plaques were stable. And they can grow slowly over time and slowly occlude the vessel, but they are not life-threatening. They don't grow any faster than the body can grow collateral vessels in general. Then we have the acute coronary syndromes. Now, the acute coronary syndromes occur when there is a rupture in this plaque. And remember, when there's a rupture in this plaque, we have all sorts of proteins in our blood, procoagulant proteins, platelet particles, and inflammatory mediators, cytokines, all sorts of other things, and they're going to be interacting with this inflamed brew that was hiding underneath that protective fibrous plaque. And what you're going to end up with is platelet aggregation and rapid clot formation. And this is going to be sort of loosely clinging to the top of the plaque and very easily rupturing and breaking off and floating downstream where the vessels get narrower and narrower. And then, if that happens, you are going to end up with one of these. Now, if it doesn't break off, it's just growing rapidly, and it may be sort of rolling back and forth, closing off the vessel a little bit and then opening it up, and you're going to end up with unstable symptoms, symptoms that aren't predictable, maybe worse at times, maybe worse at rest, and then go away and come back and go away. That is from unstable. That is because that thrombus is sort of flapping around in the vessel and causing partial occlusions intermittently. Okay, but all of these are considered acute coronary syndromes because they are all they are all life-threatening due to the unstable nature of the plaque. So the key word is unstable. So whether it's unstable angina or an MI, it needs to be addressed acutely. Okay, so let's say we've got a patient here that had a big plaque in the left anterior descending artery, and that plaque ruptures and develops an embolus, and that embolus travels downstream and occludes the vessel as it narrows here. Now, so what's going to happen? Well, all of this tissue down here is going to become ischemic. So this is all the area of that part of the left anterior that is perfused by this area of the left anterior descending. So now, remember, we talked about the cardiac myocytes, and one of the interesting things about the cardiac myocytes is that they are just packed with mitochondria because they use so much oxygen and glycogen. And remember, the blood that returns through the veins, through the cardiac veins, has a very low oxygen saturation, the lowest of the body. So the venous oxygen saturation from the coronary veins is like 25%. So these muscles are extracting every drop of oxygen out of the blood that possibly can be. So it's very hypermetabolic tissue. So, and it does not do well when the source of oxygen and glycogen is blocked. So when there's a blockage in the bloodstream, within 30 to 60 seconds, the cardiac myocytes in this ischemic area have used up their available glycogen stores and oxygen, and they have to switch to anaerobic metabolism. Now, cardiac myocytes are capable of anaerobic metabolism. Unfortunately, anaerobic metabolism can only extract about 1/10 of the energy from the substrates that aerobic metabolism can. And I'm not going to get into the biochemistry of that in this lecture, but just take my word for it. So these cells are no longer able to perform their function. So the first function that's lost is they lose the ability to contract. So they're not able to contract. The other thing that happens is, remember that action potentials depend on the constant movement of electrolytes in and out of cells. And this movement of electrolytes and the maintenance of different concentrations inside the cell and outside the cell, particularly for sodium, and calcium. These are dependent on ATP. So without ATP, we end up with significant electrolyte disturbances. And when we have electrolyte disturbances, the myocytes lose their ability to conduct action potentials. And this is made worse because also the anaerobic metabolism also causes a rise, creates a lot of the byproduct lactic acid. So we locally have very high lactic acidosis and a very low pH, and the very low pH makes these electrolyte disturbances worse and also directly impacts the loss of conduction. So we have a loss of contractility and loss of conduction. So, and this is all happening with the ischemic cells. Now, this is all reversible if we can restore flow within about 20 minutes. After 20 minutes, these cells begin to die. So if we do not get past this blockage within 20 minutes, we end up with infarction. So this here is ischemia, and obviously contraction and conduction of action potentials will not be possible after cell death. So we're going to end up with necrosis after 20 minutes. Okay, so basically after an MI, what happens is we have ischemic tissue that can still recover if blood flow is returned within 20 minutes to 60 minutes. So obviously the longer it lasts, the more tissue we're going to lose. Now, if we have ischemia and perfusion is not restored, the myocardial cells will die, and the dead cells will eventually be replaced with non-functional scar tissue. So we will have a chunk of heart muscle that is replaced with scar tissue that is not able to conduct or contract. So the fact that it can't conduct or contract, so we're going to end up with what are called wall motion abnormalities if we watch the heart pumping on an echo. So, you know, if it was a left anterior descending lesion, then we may have, you know, a significant portion of the wall that is not able to contribute to contraction. And so the left ventricle is not going to eject its contents quite as effectively, so it's going to result in a decreased EF due to wall motion abnormalities. And this can lead to heart failure, and we're going to talk about that in the next slide. And then the other change that can happen is we've got our conductile tissue here. Let me make that yellow, be consistent. And you know, we've got our pathways across the atria, and then we have the AV node, and we've got the bundle of His and the Purkinje fibers, the right bundle branch, and then the left bundle branch. And here, because we've got this big necrotic area here that is eventually replaced with scar tissue, we have a bundle branch block. So we end up with a left bundle branch block. The same thing would happen if the lesion was on the right side. We'd end up with a right bundle branch block. And you'll be able to see this on the EKG, and it's going to make the QRS complexes look wide, because the depolarization of the ventricle will not be as efficient, so the wave of depolarization is going to take more time to travel across and depolarize the muscle of the ventricle. Okay, so that ends my quick lesson on the pathophysiology of coronary artery disease and acute coronary syndromes. If you would like to view my other videos on pathophysiology, please click this link below for quick and easy access, and I'll see you on my other videos. Thank you.